Hi, and thank you for joining us. Today we'll be talking about facing prostate cancer and the life after prostate cancer treatments. My name is Dr. Sherita King.
And I'm Dr. Zach Klaassen. Thank you for joining us on this webinar. We're going to talk about prostate cancer and the treatments after prostate cancer that really affect our quality of life. Dr. King and I have known each other for almost 15 years, co-residents together in training. And now we have a very unique setup at our institution where I'm the prostate cancer treater and she's fixing the incontinence and the sexual dysfunction that comes along with a lot of these treatments. And so this is the basis of this webinar today. September is Prostate Cancer Awareness Month, and so we hope you enjoy this discussion. So just by way of disclaimer, this information is intended to be an educational resource for general information purposes only. It's not medical advice or replacement for the independent medical judgment of a trained and licensed physician or other medical professional. So this is the outline for our talk today. We're really going to be talking about prostate cancer up front, but the majority of this discussion will be life after prostate cancer. And this is certainly including urinary incontinence, or what we talk about with a patient such as bladder leakage, and certainly erectile dysfunction or sexual dysfunction after prostate cancer and the treatments that cause erectile dysfunction. So let's talk about facing prostate cancer. We know that 1 in 8 men will be diagnosed with prostate cancer in America in 2025. And so this is really important to understand your risk, but also understand the workup that goes along with deciding if you need a prostate biopsy. And the first test is the prostate-specific antigen test, or the PSA test. This is a blood test, and this is typically offered to men between the ages of 50 and 69, but may be offered as early as 40 years of age, particularly in African-American men, where new guidelines suggest that we should be testing men at the age of 45. And I think you were on that guideline that came out, which is really important. I think African-American men are at higher risk of prostate cancer, so we really should be testing them earlier. A typical PSA score is normal if it's less than 4, but this is a patient-by-patient discussion. We have men that have a stable PSA of 5 or 6, and really stability is important. And I think the point on the right is important because we really need to know what your number is. Have a discussion with your urologist. If your primary care is checking your PSA, if it's getting above 4, at least a discussion with one of us or one of our colleagues across the country is important. The next test that we often use is MRI. And so sometimes before a biopsy, we'll think about an MRI. We've got very good data from several years ago now that says that majority of men benefit from an MRI before they have a prostate biopsy. It's taken a little while for insurance companies to catch up with this, but we're oftentimes able to get MRIs. And this is really important because it gives us a lot of information. What's the size of the prostate? Is there areas on that MRI that if we're going to do a biopsy, we can target them with additional biopsies? And so again, I think the statement at the bottom is important. Each situation is different. Your urologist and you can discuss this with them. And so again, I think you don't necessarily have to have an MRI before a prostate biopsy, but in a lot of situations it is helpful. So let's talk about the biopsy. This is the only way to know for sure if you have prostate cancer or if you don't have prostate cancer. And so what this entails is removing small, tiny pieces with a needle under ultrasound guidance that we then send off to a pathologist, which is a special doctor that essentially tells us, is there prostate cancer there or is there not? If there is prostate cancer, how aggressive is it? And that really is the basis for starting the discussion about treatment. And so that's where the next sort of stages of prostate cancer come in. The early stages are what we call localized to the prostate. This is prostate cancer that has not spread beyond it. So a lot of the therapies we'll talk about in the next couple of slides talk about early stage prostate cancer and what those treatment options are. When we get into stage 3 or 4, this is more aggressive or certainly beyond the prostate gland. This may be into the seminal vesicles, which sit behind the prostate, stage 3, or stage 4 if it's beyond the prostate. And it may be in the lymph nodes, the bone, or other organs such as the liver and the lungs. And I think your physician will decide if you need additional staging. Certainly PSMA PET scan has come around the last 5 years, which really helps us stage some of these patients. And so that's important, a discussion after your prostate biopsy is done. If there is a diagnosis of prostate cancer based on your Gleason score, which is what the score looks like under the microscope, as well as your PSA level, this will decide if additional staging is necessary. When we get into prostate cancer treatments, there really is a couple of treatments that are sort of the standard treatments that we've been doing for many years. And certainly one of those, as urologists, is removal of the prostate. This is radical prostatectomy. And there's certain advantages to this. For young men, this is removing it, hopefully getting that PSA down to 0 after the prostate cancer is removed. And this is an early stage treatment. And it's now done robotically. Over 95% of cases in the United States are done robotically, which gives us the ability to get there, allows us to do certain things like nerve spare and bladder reconstruction a little bit easier with the robotic assistance. Only side effects, which I know Dr. King will get into: erectile dysfunction, urinary incontinence, always a risk of bleeding, infection, and pain. But again, one of the 2 standard treatments is removal in the right patient. This is, again, a discussion with the urologist about what treatment option is best for you. The second one that's been around for a long time is radiation therapy. This is done by a radiation oncologist. So as urologists, we work very closely with our radiation team. And this is high energy X-rays that essentially kill the cancer cells. Generally speaking, there's 2 types of radiation. One is external beam radiotherapy, where the radiation energy is coming from outside and it's targeted to the prostate gland and treats the prostate that way. The other one is brachytherapy. And this is sort of internal radiation therapy, where there's seeds or implants placed into the prostate that then allow the prostate cancer to be killed by these X-rays over time from the inside out. Again, the advantages of this are it's one of the 2 main treatments for early stage prostate cancer, along with prostate cancer removal. And oftentimes it's combined with hormone therapy, otherwise known as androgen deprivation therapy, to shrink the prostate and to help the radiation work a little bit better. But again, side effects from all of these treatments: certainly urinary incontinence, bowel problems can be an issue during radiation, and over time, certainly erectile dysfunction is a side effect of radiotherapy. On the last slide, I mentioned androgen deprivation therapy, and so we know that prostate cancer has a fuel which is called testosterone. All males naturally make testosterone, and the ADT is a hormonal treatment that's meant to intentionally block and decrease that testosterone level. And that's really the fuel for the prostate cancer. So this can be done 2 ways. Historically, it's been done with surgery, with bilateral orchiectomy, removal of the testicles. Testicles produce the majority of the testosterone in men. More commonly is a medication. This can be either given as usually 1 or 3 month injections, or as a pill, which can be taken on a daily basis. So the advantages of androgen deprivation therapy are to reduce the level of testosterone, which can basically cut the fuel off to prostate cancer by lowering the testosterone. And it can also be combined with radiation or external beam radiotherapy to help that radiation work a little bit better. Without a doubt, there's side effects of ADT. This is basically all the side effects you'd associate with decreasing your testosterone. So loss of libido, which is sexual desire, erectile dysfunction, hot flashes because the testosterone is low, and certainly changes in weight gain and changes in emotions as well. So with that, I'm going to turn over the conversation to Dr. King, who's going to talk about life after prostate cancer.
Okay, so now that you've been treated for your prostate cancer, you're on the other side of it. What is going to be your life going forward? And it's very important that we are looking at your quality of life after your treatment. We're trying to make this more of a forethought in our practice, and we try to make sure we're good and collaborating with our patients and sharing them and making sure that they're getting what they need after their prostate cancer treatment. So the American Cancer Society says that 1 in 8 men are diagnosed with prostate cancer in their lifetime, just as Dr. Klaassen has already stated. After that, approximately 21% of those patients will have either leakage and erectile dysfunction after a prostatectomy. It is important that we do know that radiation can also cause these issues too. And then after prostate cancer removal, 1 in 5 men are unhappy, and this is due to that incontinence and their erectile dysfunction. So treatment options for prostate cancer may affect your incontinence and erections by impacting the nerves and the blood flow. So after you have a prostatectomy, the nerve bundles and the blood vessels may be damaged while we're trying to remove that prostate. With the advent of the robot, we are able to spare and try to spare some of these structures. However, with removing it, there's still tension put on these things, and there's traction, and it still can have some damage caused to it. And with that, you can have incontinence rates up to 10%. And then with radiation, unlike with prostatectomy where you experience those things up front, with radiation, it happens over time. because as the radiation continues to kill the tissue and the tissue start to die off as we want it to, you're going to start seeing damage to the blood vessels within the penis, and that's going to cause you to have the erectile dysfunction. If you have post-prostatectomy incontinence and need additional radiation therapy after it, you should consult your urologist to discuss how you can treat the leakage prior to your radiation therapy. And that's very important, but you have to time it based off of your numbers. So this is a conversation that you have individually with your urologist. So the main thing that you have to remember is that incontinence is treatable. So with stress incontinence, this can really affect your activities, your daily life, getting out. A lot of patients will say that they're just staying in the house because they're afraid to go out because they don't want to leak. The other thing is that after prostatectomy, 30% of patients, or 36% of patients, will experience moderate to severe urinary incontinence. So with that, there are treatments, and just remember that. As far as erectile dysfunction after prostate cancer treatments, 47% of patients will experience moderate to severe ED after prostatectomy. The one thing a lot of people don't talk about, though, a lot of men will have erectile dysfunction going into it. So you're already at a disadvantage. Then you get the prostate cancer treatment, and now you're at severe erectile dysfunction. Don't despair. There's things that we can do for that, and we'll get into that later. Within 5 years of radiation therapy, approximately 50% of men will develop radiation-induced erectile dysfunction. And then also with prostate cancer itself is not a cause of ED, but the treatment options are what affect it. Now, I do not want you to be afraid to get treatment for your prostate cancer, because it doesn't matter if you're getting erections if the prostate cancer takes you out. So it's very important that you get this cured, because that's why I'm here. We can do things to fix that at the end. Okay, so how the urinary system works. So the brain and the bladder control urinary function. It's a little dance that they have. So as the bladder is filling from the kidneys, the bladder is storing the urine until it's ready to be emptied. As that bladder is filling, the bladder neck and the sphincter muscles are closed around the urethra, and that's what's preventing your leakage. So upon urination, when the bladder tells the brain, hey, I need to pee, then the brain sends a signal down to the bladder and the muscles to contract, forcing the urine out through the sphincter, through the urethra, and the sphincter at that time will open. Then once the bladder is emptied, it relaxes and it stops contracting, and the urinary sphincter closes again, and you're ready to fill. So what happens after you have your prostate removed? So the important thing is to know where the prostate is located. So you have the bladder that sits on top, you have the prostate, and then you have the urethra that kind of goes through that. Once the prostate is removed, you see the sphincter is located directly under that prostatic tissue. As the prostate's being removed, that sphincter will inevitably be injured. Like I said, with the robot, we're a lot better about not injuring things. However, it's not a microscope. We can't save all the little fibers. So there will be some damage to the sphincter. So when you have urinary incontinence, that means you're not able to control your urine or prevent yourself from leaking on yourself. This is when you have unintentional loss of urine, when the muscles can't hold the bladder neck or the urethra closed strong enough to retain the urine. This usually will occur when you have like cough and sneeze or increase of abdominal pressure. This happens because the sphincter is too weak, and when the bladder muscles contract, it can't hold it in place. So there are different kinds of incontinence. So I just mentioned about leaking with bending, sneezing, exercise, and cough, or heavy lifting. That's stress incontinence. It's important that we recognize differences, because with stress incontinence, that's usually a procedure that has to be done if our like physical therapy doesn't work for that. Then there's also overactive bladder or urge incontinence. So that's when you get the sudden urge to go to the bathroom and then you leak. So that's very different than the stress incontinence. Now, you can have both of those, and that's where you'll have mixed incontinence. In some men, especially those with radiation, mixed incontinence picture, because the radiation can affect the bladder tissue. And then you have overflow incontinence. that's when you're not able to get your urine out. So the bladder becomes so full, it's a balloon, it can only hold it so much. And then at that point, when it gets to its max, a little bit will leak out. And that typically will look like stress incontinence. Okay, so when we were looking at urinary incontinence, the number one cause for stress incontinence is prostate cancer treatment in men. Other causes are prostate problems, such as enlarged prostate, or if you had a surgery for enlarged prostate, that can also cause an issue. Some medications can make your incontinence worse. So that would be like your diuretics, because it can give you an urgency and frequency. Diabetes is definitely a big thing that we see in our practice. When you're diabetic and your sugars are uncontrolled, those sugars kind of attack the bladder wall, and then it can cause issues. Other things are like neurologic issues such as stroke or spinal cord injury. We have a VA locally that has a huge spinal cord unit that we see a lot of those patients. Other things can be like high blood pressure, smoking, and even obesity. Because imagine if you're carrying more abdominal weight, it's going to put pressure on your abdomen and on your bladder. So now we're going to get into some of the management options for incontinence. So these are very mild incontinence, so patients who have mild incontinence or are not ready to have surgery. Usually most of our patients will start with diapers and pads. The reason why we do that is because as you are recovering from surgery or from radiation, you may have incontinence, but it can improve over time. So what we are doing is just trying to get you through the period of where you're in that healing phase, and you're going to use some pads and diapers. These can be irritating to some patients, and a lot of patients will tend to change them more frequently because they're afraid of the social stigma of smelling like urine. Other things you can do are external devices. So those are clamps that you can put on the outside of the penis. You can use this with pads, or you can use them alone. And what it's doing is putting compression on the urethra, so it's acting like a sphincter externally. Or you can do external catheters, or like a condom catheter. And what those do are just collecting urine into a drainage bag. The other things is management versus treatment. So what we just discussed was management. So the other thing that we can do is treatment options. And these are the 3 treatment options that we have available currently in the United States. So you have adjustable balloon devices that can be placed on either side of the bladder neck. There's also a sling that is cradled underneath the urethra and then kind of goes into the pelvis for anchoring. And then you have an artificial urinary sphincter. So this is a device that is wrapped around the urethra, and it has a cuff, and then you have a pump that you have to manipulate every time you go to the restroom. So why would a patient choose a male sling? So the important thing to remember is that all treatments are not good for all patients. We have to see how much incontinence you have, because that kind of drives what treatment option that you are offered. Now, why men prefer a sling typically? Because you don't have to manipulate it. It offers a long-term solution for incontinence that's not just management for your stress incontinence. It's also less invasive and more discreet than the artificial urinary sphincter, and there's no manual intervention needed. So, like I said, you don't have to pump every time you need to urinate. The other thing is your incontinence is costing you. So every time you have to change those pads, that's money that you're just putting down the drain, unfortunately. And this can cost up to $4,000 for patients per year, especially or over 3 years if they're using 5 pads a day. And then you want to be able to enjoy your lifestyle again. Again, like I said, most of these patients are having, social anxiety about getting out because they're leaking urine. You need to be able to get back to your life. And then the good thing about the sling is this immediate continence, because with the AUS, you have to leave it open to allow the urethra to heal after surgery. But with the sling, excuse me, you're able to get back to your continence immediately. So this is the Virtue Male Sling, It is a forearm sling that, like I said, is placed in the perineal area. So that's the area between your scrotum and your anus. And it kind of cradles the urethra, and it's going to elevate and compress the urethra. So this has been designed to treat stress incontinence in our male patients. 78% of patients with the male virtue sling have reported very much or much improvement within 6 months, and there's an 85% satisfaction rate among patients. Again, I think a lot of this goes to the point that the patients are being dry immediately. In a study completed reviewing post-prostatectomy patients with the Virtue male sling at 12 months post-procedure, most of them use one pad at most. And a lot of my patients that are still using one pad is just because they're using it for security. So now we're going to get to erectile dysfunction. So what is erectile dysfunction? This means you have the consistent inability to sustain an erection sufficient for intercourse. So this means either you're not getting erections at all, you're getting an erection inconsistently, or you're getting an erection that doesn't stay hard enough to be able to penetrate. What causes ED? While erectile dysfunction is common, it is not an inevitable part of aging. So some of the physical causes can be diseases, like I said, diabetes, high blood pressure, high cholesterol. All these things affect the blood flow into the penis. Surgery, just as we discussed, like prostate removal. Also, the radiation treatments can cause this. There's different medications and substances that can cause this. So tobacco, drugs, alcohol, and even some of your medications given to you by your doctors. However, please do not stop these medications because, again, there are treatments for erectile dysfunction. And then also injury, such as brain or spinal cord injury. In these, like I said, we have a spinal cord injury unit here. 80% of the time, ED is caused by a physical problem or a disorder. So what about the psychological effects of ED? So I tell patients all the time, you have to get out of your head, because once you get into your head about your erectile dysfunction, it just makes it harder for you to get erections anyway, because you're tapping into that anxiety and fight or flight response. 50% of patients say that ED negatively impacts their life. And also 50% of patients say negatively impacts their relationships with their significant other. And that's huge. And that's one thing that I really try to work on in my clinic. 84% of patients say that ED will lead to lower confidence. I tell patients this is sort of like when women are infertile. Men feel like they're not a man if they can't get an erection. And then 69% of patients say that ED negatively impacts their intimacy. And then also negative impact on emotions are felt when thinking about the inability to achieve and maintain an erection. So you're usually disappointed, frustrated, and angry, ashamed and embarrassed, and feel inferior or insecure. And again, when you have these types of feelings, a lot of times that just makes the situation worse because it worsens your erectile function. So how does an erection occur? So when you have sexual stimulation, there's excitation. Then the brain, nerves, heart, blood vessels, and hormones all work together, again, another song and dance, to get rapid increase of blood flow into the penis. So once the blood is flowing into the penis, it gets into these spongy erectile tissue chambers that are expanding. As that is expanding, it shuts off little veins that are on the outside of the penis. When that happens, you're able to trap the blood and you get elongation and firmness of the penis. And that's how you get the erection. So what about treatment options? So we're going to go through a couple different treatment options now. My first line and most people's first line is oral medications. So those are your medicines like Viagra, Cialis, Levitra, or Stendra, which is a new kid on the block. The great things about these medications is that they will provide an erection. You don't have to do injections. You do need stimulation, though. One thing I always tell patients, this is not a magic bean. You're not going to take this and magically sprout this stalk, okay? You have to have stimulation, either you touching yourself or your partner touching you. And then the other thing is you have to have some scheduling in this. You have to take it at least a half an hour to an hour before anticipated sexual activity. So what are some of the side effects that patients will have with this? They'll complain of headaches, they'll have facial blushing, they'll get upset stomachs. Some people have back and muscle pain or nasal congestion. And then the other thing is that, remember, is that oral medications sometimes are not effective in all patients, and that's up to 40% of the cases. So if you get into using medications, oral medications, and they're not working, please consult your physician and try to get another treatment. So that next treatment for most of my patients is penile injections. So the advantages of the penile injection, unlike the oral medications, is that you're putting it directly into the penis. When that happens, that means your onset of erection is usually faster. So it's usually between 5 to 20 minutes. But there's also side effects that come along with this. One of the main ones that we're concerned about is priapism. It's very important that you are dosed appropriately for this medication, because if you would give yourself too much, you'll end up with an erection that's lasting longer than 4 hours. That's what we call priapism. That's an emergency. You should report to the emergency room for that. The other things are penile pain at the site. You can have numbness, irritation, and sensitivity at the site, also injection. You can also have bruising. For my patient, I always tell you to hold pressure for at least 3 minutes prior to stimulation to prevent that bruising. It can cause fibrosis, which is scar tissue within the penis. And again, that's if you're not holding pressure, because you're bleeding into surrounding structures, and it's going to cause like a scab within your penis. And then the other thing is very important that you get trained on this. It does require training. Unfortunately, there are some clinics out there that will just hand this out like candy. This is not something that you want to play with. All right, so then the next option is vacuum erection devices. So typically in my practice, I use it more for therapeutic benefits. So for patients who have had a prostatectomy or have had radiation, we're using it for therapy. So like if you had cardiac surgery, you're going to cardiac rehab. When you have prostate surgery or radiation, you're getting penile rehab. Okay. I call them penis push-ups. You're using the vacuum to simulate the spontaneous morning erections you used to get to help keep the tissues happy and healthy. Now, the other thing is that it's not using any drugs, medications, or injections. So some patients do appreciate that. And depending on who you ask, it can be cost effective. It's cost effective because you only have to buy it one time. But if you're getting the quality one, sometimes it can be an expensive purchase. Now, side effects. When you're putting on this vacuum, it's not that you're just putting on the vacuum and pulling blood into your penis. You also usually have to put a ring at the base of the penis. And when that happens, it's like putting a rubber band on your finger. You start to lose the warmth in the erection. The other thing is, again, having a rubber band on your finger, it can become uncomfortable. It can also be causing numbness. You can have bruising at the site. You can also have swelling. And then you can have the inability to ejaculate. And that's because of that ring at the base of the penis. And also it can cause painful ejaculation. Another medication that we have is an insertable medication. This is typically not given as much just because it's on back order a lot. But what we have are urethral suppositories. The medication is alprostadil. It's like a little rice pellet that you're putting down into the urethra, and then it dissolves in that tissue, or that medication gets into the tissue. This can give you an erection within 10 minutes if it's going to work. And our goal is to have an erection for 30 to 60 minutes. Now, the side effect with this is urethral burning. And I have found in most of my patients it's almost universal. The other thing is you can have aching within the penis and the groin, and that's just because of the type of medication it is. It can interact with pain receptors. And then finally, we have the penile implant. So with the penile implant, or Titan inflatable penile implant, there are some definite advantages to it. One, it's a long-term ED solution. So with this, the implants can last up to 10 years or more in 75% of our patients. And I've definitely seen them last longer than that. The other thing is it gives you the spontaneity back. So I tell patients you can use it as part of foreplay. That way you can get an erection as soon as you want to. Your partner can help you, or you can pump it up, and it allows you to get a natural erection quickly. The other thing is discreet, where you're not having to travel with things. Everything is concealed inside of you. And with the inflatable, you're able to deflate it so it's normal in the flaccid state. And then it also gives you control. It allows you to avoid needles and pills, and then you can get back to, and you won't have to use the clunky device, the vacuum, and you can get back to your sexual life. Now, as far as satisfaction rate, 98% satisfaction rate with penile implants with erectile dysfunction, which is huge. The other thing is partner satisfaction. Again, I say I'm very pro partner in my relation, or in my clinic. I want patients to bring their partners in, and I want them to be happy also, because they're not going to be able to use the erection if their partner is not involved. Now, so what about the malleable implant? So this is a little bit different than the inflatable. Instead of having 3 components, there's just one component. It's a semi-rigid rod. And what we do with that one is it's sort of like a pipe cleaner is the best way for me to explain it. So when you want to have an erection, you lift it up. And when you don't, you are able to conceal it and bend it back down. The advantages to this one is ease for use. So patients who don't have good dexterity, this is a great option for them. Again, it's completely concealed in the body and is less expensive than the inflatable. The disadvantages, it's always in a semi-erect state. So when you're, even though you're bending it down, it's still rigid. So you can kind of feel that a little bit more. So what about the risks for penile implants? So this is very important. Before I agreed to operate on anyone, we go through the risks in depth. So the main ones are risk of device malfunction. This is a mechanical device. It's not going to last forever. It can break down, it can rupture, it can tear. The silver lining is we can replace that if it does happen. Another important one is infection. This is very important for our diabetic patients. So they have a little bit higher risk of infection than the general population. And the reason why we harp on this is because if you get an infection and it's not cleared by antibiotics, the implant usually has to come out. And then that will cause penile shortening. The other one is inflation difficulty. It is important when you're being evaluated for a penile implant that is looked at. Can you do you have good dexterity? Can you be able to pump it up? Another important one is erosion. So that happens when there's too much pressure put at the tip of the penis, and that implant can erode out the tip typically. Erosions can occur due to incorrect sizing. So if it's oversized, you can't have an erosion, but you can also be undersized. And with that, you can have some floppy glands and issues with that. And the other thing is that once you get an implant, you're always dependent on it. So what that means is when I put this implant into the penis, it changes the architecture of the penis. It's not going to hold blood like it used to. So you really have to make sure that this is where you want to go. Now, as far as like the post-op course, I tell most of my patients, most of our guys are feeling back to their normal activities by second week. But I ask that you don't do anything that feels good to your penis for about 6 weeks. So that way we can allow the implant to heal into place. Now, as far as insurance coverage goes, most of our insurance companies will have some coverage. I will say Medicare is the easiest because it's covered under most of their plans without needing any prior authorizations. But this is something that your physician in the hospital will look into once they get you scheduled. So as far as insurance coverage goes for penile implants, they are covered under most insurance plans, including Medicare. That is usually the easiest one that I have pushing the penile implant through. It must be prescribed by a physician. An insurance specialist within the office can confirm your coverage prior to you getting on the schedule and getting into the operating room. And you can also contact your insurance company to understand what, if any, out-of-pocket expenses might be. So what do you do if you get denied? Because this does happen occasionally. You have the right to appeal any denial from any healthcare plan, and you can get a detailed out-of-pocket cost obtained from your urologist if you do not use your insurance, basically. And then you can also look for alternative insurance and financing options. So now that you've decided that you want to get your ED treated, it's important to know that not all urologists specialize in erectile dysfunction. Dr. Klaassen and I do share patients, but as soon as they start talking about their erections, he's sending them over to me because that's my specialty. He cures the cancer, I fix the problems. So you want to make sure that you find a physician who does a good number of these, because your best chance at an implant is your first chance. And a good way to do some research about the implant and to find a trusted professional is at coloplastmenshealth.com. And then also for our Spanish speakers, you can go to labombita.com. And with that, that concludes our discussion about prostate cancer survivorship and just treating cancer and what we can do afterwards to help get you through your life. Hopefully you learned lots of information. Please look into the website and try to find other physicians in your area if needed. And with that, we will conclude. Thank you.
Thank you.